Hey, Jenna, are you going to share your own slides or do you have some you want me to pull up? Okay, thank you.
Hello.
Well, my clock says 11:59, so we'll just give maybe 1 or 2 more minutes, let everybody get logged in, and then we'll get going. And this will be recorded, just so everyone is aware. If you are interested in passing it along to others or re-listening, we will have it on our website. Okay, it is 11:01, so we will go ahead and get started. I'm always late, so I give everybody that gracious 1 minute to get logged in. But anyway, my name is Dana Steiner. I work with the Nebraska Hospital Association in the quality department. And today we're going to have our first of a series talking about the antibiotic use and resistance module that is I don't think it's new, but it's becoming required for different entities. So different regulatory changes and things that we're going to learn about throughout this series. Our experts today and partners are Jenna and Lacey, and I appreciate everything that they have done to support this, and they're a great resource. So use them for all of your infection prevention needs. But I will let them do their introduction. Just housekeeping wise, I said it a bit earlier, but this is being recorded, so we will place them on on our website. And you can have access to this information if you're not able to stay on, or if you have others in your organization that would be interested. So thank you, Jenna and Lacey, for taking the time and helping us out. And I will let you guys introduce yourselves and carry on. So thanks.
Thanks for being willing to organize this for us. So my name is Jenna Preisker. I'm the pharmacist on the DHHS Healthcare Associated Infections and Antibiotic Resistance team. And I will be joined today by Lacey.
Hey guys, I'm Lacey Pavlovsky. I, like Jenna said, work with her on the HAI and AR team at DHHS, and I am the state infection preventionist. I'm also the NHSN coordination lead for the state, so that's part of why I'm on this call, to help with NHSN related general questions. So I'll hand it back over to Jenna.
And we do also have Dr. Ashraf on the line today, who's the Healthcare Associated Infection Program Director at Nebraska DHHS and has helped with a lot of this work. So he will be here to answer questions as well. You want to say?
Thank you. Thank you.
All right. It looks like we don't have a Q&A, just some more housekeeping stuff before we start. We don't have a Q&A function set up on this meeting. So if you do have questions throughout, just go ahead and put them in the chat and we'll try to address them at the end. I have a lot of information today, but I'll try to go through it a little bit quickly so that we do have some time at the end if you have specific questions for Lacey or I or Dr. Ashraf as well. All right, so we don't have any disclosures today. There is no CE, I guess, for this presentation today. It's mostly just informational. But we do have a disclaimer that none of us actually work for the CDC or CMS. And so the information we're sharing with you today is information that we've seen or received from the CDC or CMS, but we, again, don't work for either of these entities. So if you have a specific regulatory question, we would direct you to probably CMS to get those answered. So I've got 4 main objectives for today. First, I'll start by summarizing some of the benefits of reporting to the AUR module. Next, we'll address kind of one of the big things of why we're all here, the CMS requirements for AUR reporting that are beginning in calendar year 2024. Next, I want to kind of give you an idea of where to get started in the process, and if you are a little bit started in the process, how to continue to proceed in your journey to uploading data to the AUR module. And then finally, and importantly, the Nebraska DHHS HAI AR program was able to secure some funding to help hospitals offset the cost of implementing AUR. And so I'll describe how your facility can access some of that funding to wrap up today. So to get started, the basics of the AUR module, if you're not familiar with it, is it provides a way for hospitals to electronically report and analyze their antibiotic-related data. There's 2 separate options, but they function together as one module. So the first option is the antibiotic use, or AU option, which is used to assess specifically the use and rates of use in your facility of the different antimicrobial agents. The AU option includes 91 different antibiotic agents, so you probably don't have that many on your formulary, but that's all of the different agents that can be uploaded to this module. The antibiotic resistance, or AR option, is used to look at patient isolates and measure trends in resistance in your facility to specific antibiotic agents. So primarily, the whole goal of uploading data to this module for your facility is to allow you to benchmark against other facilities, both here in Nebraska and nationally, just to kind of figure out where your facility lies and identify issues you may be having in your facility with either antibiotic use or resistance. Secondarily, it provides data at the state and national level for us to evaluate trends in antibiotic usage and resistance, and potentially identify outbreaks and resistance as they happen more in real time. So when we look across the country at the percentage of uptake of the AUR module, specifically in the antibiotic use realm, we can see a large variability in percentage of facilities that are actually uploading. There's some states that have nearly 80% of their hospitals uploading data, and then there's some states that are in more the like 5 to 10% range of facilities that are uploading. Nebraska currently has 13 facilities that are reporting antibiotic usage into the AUR module. which is 24% of facilities in the state that are eligible. So we do have a little ways to go. And so likely this mandate that's coming out next year will greatly increase this percentage of reporting facilities. One of the things that we can see nationwide using the antibiotic use data that's uploaded into this module is how many facilities essentially are seeing overuse of antibiotics in their facility. So if you're in the infection control world, you're probably used to seeing the SIR or SIR. Antibiotic use has the SAR, or the antibiotic administration ratio, and it functions very similarly to the SIR. So if you're using more antibiotics than expected, your SAR will be over 1. And so as we look across the country in different types of facilities, we can see in adult, pediatric, and neonatal facilities, we're still seeing between 20 and 30% of facilities reporting usage over their SAR or their expected usage rate. So we're seeing pretty much nationwide, there's still some room for improvement in antibiotic use. So when it comes to benefits of AUR reporting, when we look at the facility level, it does provide you a benchmark for antibiotic stewardship and really helps to identify what your antibiotic stewardship needs to work on from an quality improvement initiative standpoint. It also allows you to compare your use with trends across the nation. So a lot of facilities right now may be calculating their antibiotic use either manually or through a report in their EHR system, but it doesn't really tell you how you're doing compared to everyone else. It gives you maybe some numbers that you think you could use to make adjustments within your facility, but without that SAR value, it's really difficult to kind of identify where your problem areas really are within your facility. Another benefit is if you're familiar with Nebraska ASAP, the Antibiotic Stewardship Assessment and Promotion Program, each year they're providing letters with antibiotic stewardship guidance specifically related to the data that your facility uploaded into the antibiotic use module. And so we help kind of identify trends in your facility for you that may be higher usage and give you some ideas on how to investigate that higher usage and maybe some guidance on what to do about it as well. On the other side of the coin that hospitals are particularly interested in from AUR standpoint is the regulatory and payment benefits. So we'll discuss further the CMS requirements for next year, but this also helps you to, if you are a Joint Commission accredited facility, helps you to meet the tracking and reporting requirements for Joint Commission. And then the CDC also has found this to be very important for a robust stewardship program. And so they rewrote priorities for core element implementation in facilities in 2022. And they added that the hospital submits antibiotic use data to the NHSN AU option as a major priority for their core elements of implementation. Okay, so let's transition into answering some more questions about the CMS requirements that are upcoming beginning in calendar year 2024. So starting January 1st of 2024, AUR module data are required under the Public Health and Clinical Exchange Data Objective for the CMS Promoting Interoperability Program. If you're not very familiar with this program, it used to be called Meaningful Use 3. That's how I am more familiar with it. But really the goal of this program is to improve information exchange from an electronic standpoint in facilities. And so this really falls well under that category for CMS as it allows better antibiotic use and resistance information exchange. The measure to meet the requirement involves submission of both AU and AR option data. And so we do have a lot of facilities in Nebraska right now. I showed those 24% of facilities that are submitting. That was just the AU data. There's a much smaller percentage of facilities submitting the AR data right now. And so to meet this measure, you'd have to do both AU and AR. And this does apply both to acute care hospitals as well as critical access hospitals that participate in the Promoting Interoperability Program. And so I guess the biggest question we usually get is, how do I know if my facility is even participating in this CMS PI program? How do I know if we need to do this or not? And so I guess the short answer is there is significant reimbursement and a lot of money to your hospital involved in participating in this program. So most facilities are participating in it. Your person in charge of quality reporting can clarify that for you. They have to report quite a few different things for this measure every single year. And so they will definitely know if your facility is participating or not. There are 3 types of facilities listed here: inpatient rehab hospitals, inpatient psych hospitals, and long-term care acute hospitals that are not included in the promoting interoperability program. And so for the CMS requirement, these 3 types of hospitals are not included in the requirement. However, those 3 types of hospitals are still eligible to upload data into NHSN for AUR. And so where their reimbursement isn't tied to it, they still are able to participate in NHSN. So I took the pleasure of reading through the whole many thousands of pages of the IPPS document from last year to try to better understand why they decided to add this requirement for reporting to the AUR module. And so these were kind of their arguments as to why they decided to make this mandatory. The first was that growth in voluntary reporting since the module was implemented back in 2011 has grown exponentially over the last several years. And so the fact that over 3,000 hospitals are putting data in here in the country while it's voluntary, they believe that hospitals are finding the data to be very useful and can be very beneficial to them. Their second argument was that there's so many other things already required into NHSN for infection control purposes, including bloodstream infections, hospital-acquired UTIs and CODIs, other things that are being reported at a very high national compliance rate of 97%. And so they felt if facilities can get to that high of compliance with healthcare associated infections, they can also get to that higher compliance rate with antibiotic use and resistance reporting. The third reason they listed was that if we have incomplete participation throughout the country, it really limits our generalizability of the data. Having an incomplete data set would really kind of bias the data towards the facilities that are reporting. And then their fourth argument is that this data is very useful. And so as we have more of it available, we'll hopefully become better at detecting emerging threats and be able to identify them sooner. So in order to meet the requirements for the CMS 2024 Promoting Interoperability Program, facilities have 2 options. The first option is to be attest to being in active engagement with NHSN to submit AUR data, or to claim an applicable exclusion. So we'll go over both of those options for facilities. First, let's look at being in active engagement and what does that mean? So you have 2 options to be in active engagement in NHSN for AUR. The first option is to be in the pre-production and validation phase. So essentially thinking we're working on getting this up and running. And so for the year of 2024, if this is where your facility is, this will meet the requirements. So you have an entire year to work on your build, pre-production, and validation phase. You don't actually have to have data uploaded and available for them to review in 2024. So I think that clarification on the timeline helps us breathe a little bit easier. We do have a little bit more time because this pre-production phase does meet the requirements for the year of 2024. If you've already done the pre-production phase and you're ready to start submitting data for live production, you can also be in active engagement by picking option 2, which is submitting validated data production. So active AU and AR data into NHSN. So I think most people are probably looking toward the option 1, active engagement on this phase. So the other option, if you don't want to do either of those things, or you don't think your facility can do either of those things, is to claim an applicable exclusion. And so they list 3 different exclusions for reporting that facilities can claim. So the first is that either the hospital or critical access hospital does not have any patients in any patient care locations. I would imagine that very few hospitals in Nebraska would meet this. This is for like very specialized, specific surgical hospitals, or hospitals that provide very specific type care only specialty hospitals. We don't really have any of those in Nebraska, so most people won't be able to claim the first exclusion. The second exclusion, however, the data has to flow over from your electronic health record with the administration time that the nurse gave the antibiotic to the patient in your electronic health record. So if you do paper charting or any manual charting of administration times, you won't be able to submit antibiotic use data. It has to come straight from your electronic health record. I would imagine there's very few, if any, facilities still doing all of their charting on paper. So most people probably won't meet the second exclusion either. The third exclusion, however, several facilities may meet at this point, and that is if your hospital or critical access hospital does not have an electronic laboratory information system. So essentially, if you use an outside lab to send out your cultures to be done, and that outside lab does not transmit information back into your EHR. So if you can't open the patient's record and look at their culture and see all of the sensitivities within your electronic health system, if you get a paper faxed back to you, or you have to get into a separate system to look at your culture results, this would likely qualify you for an exclusion for reporting to the AUR module right now. However, it was written in these 2023 guidelines here that CMS put out for these exclusions, that they are planning on reevaluating these exclusions every year, and that they won't necessarily always be applicable. So they may remove some of these exclusions coming up here in the next few years. Some of the software vendors we've been speaking to can actually work with your outside lab. So while you can claim this as an exclusion, you may be able to work around it, and we'll talk a little bit more about that later. And then just as a disclaimer, everything I'm telling you is from the 2023 rule cycle, and they're in the midst of writing the 2024 rule, which usually comes out in August. So as of right now, from their draft proposed rule, there aren't any changes to this information, but just disclaimer, you never know what they're going to write for next year. So if you're wondering, is there anything due now? No. There's currently bonus points available for reporting in calendar year 2023. But as we've discussed, this will change in 2024 as it becomes its own required measure. So that's all I have for the CMS requirements. I know there's probably a lot of questions in regard to that. You see the chat is kind of got a lot of things in it. I'll address those at the end. But now I'd like to transition over to how to get started in the process of reporting data to the AUR module. So first, just to explain where this data lives within NHSN, it is within the patient safety component. So this is nice because this is the same place that infection preventionists are already reporting all of the healthcare associated infection information. And their multi-drug resistant and C. diff information. So it's a module that we're at least a little bit familiar with in the hospital world as compared to a lot of these other components within NHSN. And so this also helps with your setup because it's going to go along with all of your other infection control things on your locations are going to be the same. The monthly reporting plans are located in the same place as your infection control data. And so it helps from the setup process that it's in a familiar place to most of us. One thing that is a little different, however, from the infection control data is the requirement for data submission. And so every other module in the patient safety component allows manual data entry. So it allows you to one by one upload your data into NHSN. However, the AUR module requires electronic data submission. And I'll explain a little bit more in a couple slides why that is. So these are the data submission requirements that your electronic health record has to have. And you'll see they align with those 3 exclusions. So if your facility can't get this information out of your EHR, then that's when you qualify for those exclusions. And so again, just as a reminder, the first was having the medication administration documented in your electronic health record through either barcode medication system or just electronic charting by the nurse. Secondly, having electronic lab information flowing over to capture your antimicrobial susceptibility results. And then finally, to get the location level data, you have to have an electronic admission, discharge, and transfer ADT system to track patient movement. The results you get out of NHSN on your analysis reports shows you antibiotic usage levels on different floors and patient locations within your hospital. So that's why they need to be able to have the ADT information as well. And then secondly, your EHR system has to be able to package the data in the specific format that NHSN wants for its upload to be available. And so there are three different ways to do that. First is to use essentially a third-party commercial software vendor that basically taps into your EHR, pulls out this information, packages it like NHSN wants to see it, and then allows you to upload straight into NHSN. The second way is as part of your current electronic health record system, a lot of the larger vendors have like an add-on capability that you can purchase to be able to do exactly that, pull that data out, package it how NHSN wants it, and then allow you to upload it to NHSN out of there. And then the third way is to essentially write your own code and kind of home grow your own code to be able to do this. This is really kind of not recommended by the CDC because it just takes a lot of maintenance. They change a lot of these definitions throughout the year. And so you'll find that maybe your code starts to fail and then you'll have to look into how to get it corrected and fixed. And so they really don't recommend trying to home grow your own code to do this because it just takes so much database maintenance. So just to touch on a little bit why we can't upload this data by hand or manually like we do with other components of infection control is that there's just simply too much data to be uploaded by hand. So it wants to know every single dose of every antibiotic administered, what time it was given, what date it was given, if it was given IV or PO, and where the patient was at that exact moment within your hospital. And like I said, there's 91 different antibiotics it's looking for. And so even if you're a very small hospital, this tends to be a ton of data. And so there's just no physical way that anyone would have time to manually enter all of this by hand themselves. And so that is kind of the reasoning behind the requirement for the electronic upload. You'd also have to upload every susceptibility for every single organism. So if you have an E. coli in the urine and you report out 15 antibiotics, you'd have to manually upload all 15 of those antibiotics for every single culture that is done. And so it just becomes way too labor intensive to imagine doing this by hand. One thing that kind of different than the infection control data is that the antibiotic use data and antibiotic resistance data are sent on an aggregated level. And so it's not really getting any patient specific information out of your hospital into NHSN. What it's getting is we gave 18 doses of ceftriaxone on this floor on this day, and then your patient census. And so I think that's a good thing to remember too, is that they're not really pulling patient specific information out for this use. And so we get asked a lot, like, this sounds like a lot of work. How long is this going to take me? But depending on the size of your facility and how many different floors you have on your facility, typically it takes around 15 to 30 minutes to do all of these uploads once every 30 days. And then you spend some time looking at your analysis and reporting, but it ends up not being too labor intensive at all once it gets set up for you. So another question is, how often does this data need to be uploaded to NHSN? It's recommended to upload the data monthly. They recommend uploading within 30 days following the completion of the month. And per the PI program, you're supposed to continuously upload your data on an ongoing basis. And so best practice for this would just be to set a day. I always uploaded mine on the 9th of the month, but just to set the same day every month and sit down and do the upload. And like I said, it usually takes 15 to 30 minutes at the most. So once your systems are all set up, it's not too painful of a process to upload this every single month. So the next really important step is, as a facility, to start looking into software vendors and kind of discuss these next few bullet points within your team and within your hospital. So the first is going to be cost considerations. There is a very vast range of cost associated with this. There are some programs out there that can do this for under $1,000 a month for your facility, depending on the size of your facility. There's some vendors that have several $1,000 startup costs between, I've heard $4,000 and $6,000 for startup costs, but then the monthly cost is much lower. And so this is just something you need to look into these different vendors and decide for your facility how you want to handle cost and what you can afford to do. The next consideration is, are you going to use your hospital's electronic health record that's already in place and try to purchase an add-on to it, or bring in a third-party software? I will say, from experience working with facilities, just doing the add-on to your electronic health record is not always the easiest way to go. Sometimes these third-party vendors actually work more seamlessly and easily and take less setup than doing an add-on to what you currently have and staying with the same company that you are already using. So just keep that in mind, that maybe some of these smaller third-party vendors can be cheaper, faster, and work just as well for what you need to accomplish here. Also consider any additional features that the software is trying to sell you. Some of these softwares will literally just upload AUR data and that's it. Some of them provide a whole bunch of different capabilities with their software, including prospective audit. So if you have pharmacists that are looking for tools to improve their rounding ability, to look for drug interactions, renal function, some of these vendors have that as like an additional feature. But again, remembering that comes with an additional cost. So just something you need to decide as a facility if that's all those additional features or something you need, or if that's cost that can be avoided because you already have something in place. Implementation timeline is another consideration. Some of these vendors take 4 to 6 months to get things up and running. Some of them can have things up and running in a few weeks. And so kind of as you get closer and closer to the deadline for this requirement going in place, that may come into play a little bit more. That's why I think it's good to get started on these conversations earlier so that you don't get crunched on implementation timeline because some of the vendors take a really long time. Also consider how much IT involvement. If you're, that's wrong. If your facility doesn't have very strong IT support, or you don't have someone on site that can do a lot of IT work for you, some of these vendors don't require IT really to be involved at all. We talked to one vendor that was able to set up a facility just talking to the infection preventionist and never even spoke to an IT person at all. And so something to keep in mind, other vendors have very heavy IT involvement requirement to get set up. Next, I would just recommend watching some demonstrations. We're trying to work on getting a few different vendors to give demonstrations on this webinar series, so you can maybe watch them there, but maybe have a discussion within your facility. And if there's a couple you're interested in, I would highly recommend just watching a demonstration to see what they can do with your EHR. And then finally, make sure to talk this over with your C-suite. Again, this is going to cost probably several $1,000s. We do have funding available, which I'll discuss later, that you can take to your C-suite as well. And then also let your IT services know that you want to be implementing some new software potentially, or expanding on your current software system. So I talk about all these vendors. When it comes to choosing which vendor you want, I've included links on this slide to the validated vendors that NHSN and CDC recommend to use. So I would definitely use one off of this list here. Okay, now I'm going to hand over to Lacey.
Awesome. Thanks, Jenna. So I'm just going to go over some things that your facility can do now to get started. So if you go ahead and go to the next slide. Thank you. The first thing you want to do is make sure that you are already fulfilling the basic requirements of data submission to NHSN. As far as I'm aware, I think every single hospital in Nebraska is already enrolled in NHSN. This actually just happened with the COVID-19 hospital data reporting. So to my knowledge, every hospital is enrolled. So that's not something that our state has to worry about. But we need to make sure that hospitals have mapped NHSN locations. So that would be, you have your inpatient units, your ED and everything mapped correctly into NHSN, which if that's something you need help with, I can help you out with that actually. So you can touch base with me. Another thing is to make sure the hospital has a facility org ID, which you should be able to find in your, when you log into NHSN, it'll tell you what the org ID is. You also want to start getting your pharmacist involved who assists with any antibiotic stewardship efforts in your facility. You may have a dedicated pharmacist for that, but some of you are very small. So we know it's not always possible, but you need to get your pharmacist involved in this process and get them added as NHSN users if they are not already, which we'll go over on the next slide. But the other things you can do now is to complete the online AUR module trainings. So these are great trainings that NHSN has already put together. They will take you a couple hours. I think it's well worth your time. There are trainings on the antimicrobial use option and the AR option. So definitely, if you're only going to do a minimum, do the ones that are in blue there, but the advanced analysis and all those other module trainings are very helpful. So you can see what kind of data and things you can get out of NHSN to help you with your stewardship efforts. If you go to the next slide, adding an NHSN new user, a lot of you should be familiar with that process now, having had to do that for your COVID-19 data reporting, but this is a reminder. The NHSN facility administrator, whoever that is at your facility, a lot of times it's your infection preventionist, has to add a new user. So like your pharmacist or anybody else you want as a user. There's a link on the bottom of this page on how to do that. It's a pretty simple process. It ends up sending them an email and they have to get SAM's access just like everybody else did. And then the administrator will have to assign that user rights, and you can see here. So say you're adding your pharmacist, you want to make sure that they have the correct rights for the AUR and AR module. And you can see right here, you just click on the little boxes. It's really easy when you're going through that to make sure they have the correct rights. If you go to the next slide, other next steps you guys can do is to register your intent to submit data if you're not gonna do an exception. So the eligible hospital must first register the intent to submit AUR and AR data into NHSN, and we have some screenshots on what that actually looks like. The facility should not register intent to submit data until they have verified that the vendor being used is ready or almost ready to submit data. There's a 90-day response clause in that, so don't do this until you're really close to submitting data. Failure to respond twice within an EHR reporting period would result in the facility not meeting that measure. So that's just something to keep in line or like in your mind when you're looking at your timeline, like Jenna mentioned. And just so you know, only the NHSN facility administrator can view and complete this task. So when this is done, I would recommend taking a screenshot or printing it out and having that available so you have that documentation that you'll be able to prove that you did that and you can share with other people in case they ask. But just make sure that you know only the facility administrator can complete this for you. If you go to the next slide, this is what it looks like for the AUR PI program registration. It just looks like a lot of the other NHSN things, but you go to facility and then you would go down to the AUR PI registration page and fill this out. It's actually a pretty easy process to get done. If you go to the next slide, you also, when you're looking at the validation of the AUR CDA files, NHSN will send the facility an invitation letter to begin testing and validation. 3 test CDA files are to be mailed to NHSN, and there's the email if you have these slides when you begin that process. And it needs to follow the specifications outlined in the invitation. So you need to ask your software vendor for these specific things. They're listed right there. And then the NHSN will receive and validate the test files. Details will be returned to the facility in an email. They'll tell you any errors that were in the file, and then that facility can work with the vendor to correct the errors if there are any and resend them to, they can resend updated test files. So it might take a couple times, so just know that that could happen. They will let you resubmit the test files. And then once the testing and validation steps are complete, the facility will be invited to submit AU and AR data into NHSN production environment. Prior to uploading the AR AU files, you need to make sure that the AUR is updated on your monthly reporting plans within NHSN. So your locations for monthly recording plans must be specified. So here's an example of what all of your different locations could look like. And the same monthly reporting plan, you can use the same one that is used for your HAI reporting. So that shouldn't change. And I think I'm handing it back over to Jenna. Jenna, you're on mute.
Okay, thanks. So I know a lot of that maybe sounds stressful and confusing with all the vendor and all the uploads and NHSN requirements, but that's the point of working with those software vendors. When we've done demonstrations, they've set up hundreds of hospitals now, so they'll know exactly when you tell them I'm ready for the test files or NHSN's asking me for the test files, they will know what to send you. So please don't get stressed out about all of those different things. The point of the whole thing is it has to be electronically uploaded. And so if your files aren't working, it's on your software vendor to figure out why and how. So please, if you're the clinician on the call, you're the infection preventionist or the pharmacist or the quality team member, please don't get stressed out about the IT end of things. This is what your facility is going to be paying the software companies for. So I just wanted to put that out there because it sounds like very intimidating and a lot of work. Okay. So the last thing I want to talk about in the next maybe 5 or 10 minutes here is the Nebraska DHHS HAI AR support project for reimbursement of some of the AUR implementation costs. Dr. Oshoff, did you want to present these?
No, it's okay for you to present, Jenna. That's perfectly fine. I will just say I realize that there is a kind of a typo in there where we are saying January. It should have been a February. So just 2022. It will be on a couple of places. Yeah. Okay. Yeah.
Okay. Thank you. Yeah. Okay. So I really wanted to bring to this group this funding assistance money that we've secured through a CDC grant to help facilities be able to offset some of the cost of putting this in place. I think this is a great opportunity for our state. We've obtained a pretty large amount of funding and we'll be able to help out a lot of facilities with it. And so we're excited to share this opportunity with all of you. This funding will be distributed by a reimbursement process for the expenses that your program incurs between February 2022 and July 2024 is when the grant is active for. And so again, just stressing this is a reimbursement process. And so we would need you to have things in place and already paid for before you're eligible to get the funding back from us. It will be in your best interest if you're going to work on this to get started as soon as possible so that you can get some of those invoices available to send on to us for reimbursement. If you're wondering how much reimbursement we're talking about, it's really based on the licensed bed size of your hospital. And the reason for this is that when we looked at all the different software vendors, they typically charged more for the more beds you have in your facility. And so we did some calculations on average cost that a facility should incur to get this set up and landed on these numbers. So facilities less than 100 beds can request up to $10,000 for reimbursement from DHHS. 101 to 200 licensed beds can request up to $15,000. And then a facility with over 201 licensed beds can get up to $20,000 in reimbursement. So pretty good amount of money that will help, at least with startup costs, to get this put in place. So the expenses that are eligible for reimbursement from Nebraska DHHS are technology enhancements that you have to purchase as a hospital. So if you purchase add-on software like a third-party vendor to be able to upload the data, or if you have to make a purchase of your existing electronic health record, most of the existing like Epics and the Cerners that have this capability available, it's an additional purchase on top of your existing functionality of your health record. So even if you have an electronic health record that has the capability, you're probably going to have to put down a capital purchase to get it up and running. You can also be eligible for reimbursement of staff time spent on implementation activities. These staff include your pharmacists, hospital administrators, infection preventionists, IT, quality personnel, and physicians. And then any other related expenses based on our program's approval. So I think I wanted to kind of list out what your facility would need to do and provide for documentation to be eligible to receive this reimbursement. I think when a lot of facilities hear grant money, they get scared if they have to write a whole big grant and do all that. Well, we've really streamlined the process to make it as easy as possible for everyone in the hopes that everyone can be able to access this funding. And so the first step, we would ask that if you haven't recently participated in a stewardship assessment with Nebraska ASAP, that you would just click the link and kind of fill out a baseline stewardship program assessment at your facility. It has maybe 30 questions and will take about an hour for your facility to do. This is something that can be done by your stewardship team. The next thing would be, and perhaps the most important thing, would be to complete the online survey indicating your interest in. Oh, yeah, go ahead.
Can we also change that to February 1?
Oh, sure.
Thank you.
We're just going to do it so I don't forget. Okay. And so the second thing is that the facility should complete an online survey, just indicating your interest in participating in this reimbursement process. Again, this is about a 20-question survey. It's like, what is the name of your facility? Kind of what is your plan? There's a lot of yes or no questions. So not a huge lift on time for your facility. Even if you're only considering participating right now, I would still encourage your facility to just go on and fill this out just to get your name on the list. If you end up deciding not to pursue reimbursement, totally fine. This is kind of just an inventory list of interest right now that we'll use if you decide to start submitting invoices in the future. So please just take a few minutes maybe and fill this out just to kind of get your name and contact information on the list so we can work on reimbursement with you. The next requirement is that we would need to be able to see at least 1 month of your data actually showing up in NHSN and available for review by Nebraska DHHS. So just kind of proof that you're actually doing the uploading. And then finally, we would just need a submission of your receipt and invoice. And if you're going for staff time reimbursement, we have a form with DHHS that you just fill out showing the staff time and rate and all of that good stuff. That would also be on an online survey that is still currently in development. So the other thing, this whole reimbursement is pretty much hot off the press. It just got approved kind of earlier this week. And so we're in the process of getting it added to this healthcare associated infections website at DHHS. That's the link on the bottom of the slide. So a whole document explaining all of these requirements and benefits of participating in this will be listed very soon on the Nebraska DHHS website, as well as the links to these 2 surveys that would be required. So just keep an eye out for that coming up, hopefully very soon. And so just wanted to finally provide you with some other resources if you have further questions. The NHSN help desk is an option. They may take a little bit to get back to you just because of all the facilities in the entire country are going live with this right now. And so responses have been a little bit slow, but I think they are getting back to people pretty well eventually. There's also, like Lacey mentioned, the training websites are really good. They have pretty in-depth videos, even off the things that I just briefly mentioned today about what the reports look like, how to interpret data, all that good stuff. They have some good videos that can be really helpful in guiding you to understand what's all required as well. If you have CMS, reimbursement, regulatory related questions, there's an email address here specifically for NHSN AUR questions, and then a phone number as well that you can call. And then finally, Lacey and I's email address is here as well. And then the last thing I want to say is the Antibiotic Stewardship Summit is Friday, June 2nd. The NHSN AUR module is a topic on the agenda, and we're having one of the pharmacists from the Tennessee NHA AUR program fly into Nebraska to talk about the AUR module. Tennessee went through this whole process started back in 2018. And so they've had a little bit more experience than the state of Nebraska in getting a wide range of different facilities up and running with AUR. And so I'm really interested to kind of hear his experiences. And I think we can have some things to learn and so a model to follow for the state of Nebraska, kind of learning from what Tennessee did. And so this would be a good opportunity if you're interested to join us. The registration link is on here too, and learn a little bit more about AUR as well. Now I'm going to go back to just leave it on this slide in case you didn't get our email addresses down. But we will work on maybe the chat first and then open it up if anyone has any more questions.
Sure, do you
Okay,
want me to ask the questions, Jenna?
sure, go for it.
Okay, so I'll scroll to the top.
Can I make a couple of comments, Jenna, just real quick? You know, as of this point, this is the first time we are announcing this, so you will not find that information on the NHA AUR website yet. This has just gone through our legal review and everything, and we got an okay. So we wanted to share with you as soon as possible. The official announcement hopefully will come on our website by next week, I'm hoping. So you will probably find all this information on the website also. In terms of how much money we have secured, as of now, as of today, we definitely have enough money to, I think go up to probably what 35-40 hospitals in the state, Jenna, depending on which size hospitals that are applying, and we actually believe that there is a chance that we will be able to secure more funding that can even allow us to make it available even for every single hospital in the state. We're working on it. So as of this point, it's still, you can get reimbursed until the supply lasts, correct? Until we have the funding to be available to give. So hopefully we will have enough to give to be able to help everybody. But at this point, it is, we think it's about 35-40 hospitals easily that can get help through this funding. But if things keep changing, we'll let you be aware when we get the more funding available. But for now, just think about it at this way, that if you do it early, you probably are first in line to get the reimbursement also, because you will submit it first. So that's another point that I want everyone to be aware of too. Is there anything else? I don't think so. I think that was the more important points. Jenna, did I miss anything else that we were supposed to share? Okay,
I don't think
good enough.
so. There was a question in the chat about that, so you answered one of the questions. Thank you.
Okay, good
About
enough.
limited funding, so.
Yeah, yeah.
Alright,
Well,
Lisa.
I will not call it limited. It's still 35, 40 hospitals. That's like close to getting close to 50% of the hospitals in the state. And then we do have reasons to believe that we can secure more. That can even help us to get to hopefully even 100% of the hospitals. Yeah.
Sounds good.
Okay, so one of the questions I think we answered already, but it was, what are the exclusions? Did you want to go back to that slide? Just to review those again for critical access hospitals.
Yes. Those are the
So technically, I have to correct myself. Technically, it is limited in that sense that right now. So the question, I read the question now, it's limited in the sense of, yes, for now it is limited, but hopefully it will be enough to cover everybody in future.
I guess while we're on exclusions, I did want to say one more thing related to our funding is, if you're excluded because of the AR and your limitations of an outside lab, you can still participate in antibiotic use. So you won't meet your promoting interoperability, so you'll have to claim an exclusion for that. But I do want to be very clear that CMS requirements and NHSN, AU, and AR are completely separate entities. And so even if you're choosing to take an exclusion for CMS, you can still upload your AU data if you have that half of it available for your hospital to use that data. I also want to re-emphasize that they said these exclusions are probably going to go away. So while it will get you kind of out of it right now, our funding is only available until July of 2024. So if you could even get your antibiotic use half of it set up, we can give you funding for that half of it. And then maybe you can address the AR side of things in the future if they remove that exclusion or if things change with your lab system in the future. And so it's kind of a make it a stepwise process, perhaps. If you're claiming the exclusion for your lab, you can still maybe try to do the antibiotic use data and take advantage of some of that funding that's available right now. Okay.
So one of the questions that's close to that, Jenna, which
Yeah.
I think you can elaborate on this, is that there one facility is looking at the exclusion for not having an LIS because it's electronic. When they get the culture reports back from the reference lab, the results and sensitivities are just reported as a comment. So there's no data in the fields. It's entirely free text. So this was something you actually talked with one of the vendors about. So I didn't know if you wanted to.
We did. So this for CMS, again, separate entities, CMS, this would be an exclusion that you could claim if that is the case. Since they come through as comments, it has to be discrete line item data that the electronic health record can pull out in order to be able to upload. So for CMS, you would be exempt, yes, in this situation. However, you don't have to be exempt. If you choose a vendor, sometimes that vendor can work directly with your lab itself and kind of skip the hospital, and they can pull the data they need straight from your outside vendor for the AR data. And so they do have some pretty good experience, different programs doing that. And so I don't know if that answers your question, I guess. Yes, you can claim exemption, but there's also probably a way that some of these vendors can work around it. And I think they could probably talk better to that if you're able to join us, if we can set up some software demonstrations. They had a really good examples of how they're kind of able to work around the lack of communication between the outside lab system and the hospital's EHR system and still get the data they need for you to be able to meet those requirements. So it can kind of go either way, I guess, in essence.
But it would be beneficial if you have the time to do it now because you get the reimbursement now to look into that vendor and those kinds of things than waiting for when the exclusion's gone, the funds are no longer going to be there anymore. So for reimbursement. So I just think.
Yeah, and the vendors made it sound like it's not too painful of a process for them either to work just straight with the outside lab and get the information that way. So again, I'm not an outside, like I'm not a software vendor and I'm not an IT person, pharmacist.
Well, and
So,
that's an
but they-
important point, Jenna.
Yeah.
That's an important point that, we're not endorsing any vendors or anything from the state side. I think Nebraska Hospital Association have talked to some vendors to come and present or will have the data from them. But from the state side, there's no endorsement. We don't kind of prefer one over the other, or, even if they are not if they are not someone who are on this call series or something, they're still okay to talk to them as long as they're meeting all the criteria.
Yeah, and that's why I shared that list of vendors, because again, like I had on that list of things, some of them have very different costs associated. Some of them have very different implementation requirements for your facility. So it kind of pays to just talk to a few of them and see what's all available to you. And hopefully we can help. Well, Nebraska Hospital Association can help with maybe arranging some demonstrations that I think would be very beneficial. So,
Another question.
Dana, I guess, do we have a way to get these slides to people, I assume? We'll figure that out. We'll make sure we get these slides.
Get unmuted. Yes, I will. When we put the recordings out, I'll just put one link for slides and one link for the recordings, and they'll have them both.
Okay. Sounds good.
Awesome.
Yeah, just remember, if you're going to try to find that information anywhere on the website right now on the state, you will not see that. As I said, it's just fresh, very, very fresh, got reviewed, got approved. So we wanted to share with you guys right away. But yeah, official announcement will be coming later.
And there's one other question on if we had any examples of CMS reimbursement for participating in this program. Guessing they're meaning the interoperability program. So no, I don't have any. Dana, would you be able to share anything like that?
Are you meaning like people that have been either more highly reimbursed or taken a hit for not reporting? Is that what you're looking for?
Yeah, this is Jenny Melham. You just said there was significant reimbursement from CMS for reporting the AUAR data. I just didn't know if anybody had examples of what significant reimbursement was.
Well, so I don't have a specific number, no, but in calls we've been on it for larger facilities, it's like in the millions of dollars of penalty that they will get if they don't upload. So what that means for a smaller facility, I'm not sure, but that's the wording that CMS themselves used, is that there will be significant penalty for not doing this. So I'm not sure what that means. I haven't been, it's kind of like a buzz in the pharmacist world. We're all like, what does significant mean? No one's been able to nail down an exact number. They've never penalized anyone for it before, since it's a new measure. So that I haven't been able to figure it out, but
No, that helps.
kind of.
Typical CMS, scary
Yeah,
word,
right,
no
right.
specifics.
Right.
Very good. All right. Well, we are at our hour. Thank you, everybody, for joining us. Thank you, Jenna, Lacey, Dr. Ashraf, for all of your wonderful information. We will work on getting slides and recording on the website shortly, and then join us in a couple weeks for the next session that we will go into some more specifics. And we'll see if we can't dig more into what the penalty looks like and those kind of things. As we hear more, we'll keep everybody aware, as I'm sure more information comes out regularly. Jenna will share with us, and we'll keep everybody as up to date as we can. So thanks, everybody. And if you do have questions that we didn't get to or further clarifications, you can reach out to me. I think Jenna's email is on the slides. I would send it to Jenna, even if you sent it to me, so I can be your throughput. So anyway, so we can get those questions to them if you have things that you think of or other people in your organization think of. So thanks, everybody. Happy Friday, and we will talk to you soon.
Thanks.